We left off with the respiratory anatomy. Let's move on to some pathology. So this is called a histological section. So they've taken a small little piece of lung tissue and put it under a microscope. This shows the difference between type 1 and type 2 pneumocytes. These are, let me get the color that will show up here. Pneumo means a little thicker. Maybe that one. Pneumo means lung. Cyte means cell. So these are lung cells. You got two different types of them. Type 1 is this super thin right here. Only one cell layer thick. You can see the nuclei. There's one there. Definitely one there. These are type 1 pneumocytes. They're only one cell layer thick. And they'll have capillaries all around them, which we'll talk about when we do the cardiovascular unit, which I'm holding off on in hopes that still maybe in May we'll be back in school and we can do those dissections. But we'll see about that. The other type of pneumocyte is the type 2 one. Jeez, I don't want that to do that. Type 2. And this one makes secretin. And secretin keeps the lungs from collapsing. So that's a really important liquid that is secreted by type 2 pneumocytes. Sometimes in infants, when they're born, they don't have enough secretin to keep their lungs from deflating and collapsing. And so you actually have to give secretin through the mouth into the lungs to save the baby. Prior to modern medicine, that would have been a death sentence for babies. It was, used to not be such a births didn't always used to go quite so well as they go today. All right, so let's talk about alveolar gas exchange real quick. Basically, you just have right inside here, let me switch to a little darker color. This is inside the alveoli. And then this is inside the capillary. So when you breathe in, oxygen is going to be high here, and oxygen levels are going to be low here. Let me switch that to over here. And so oxygen will flow from high to low concentration and go into the capillaries, where it's going to get into a red blood cell and join with hemoglobin, whereas CO2 levels will be high here. Here's another alveolar space down here, by the way. And so this up here is alveolar space, and this down here is alveolar space. And CO2 will be low here and low here because these are the same spaces. So CO2 flows from high to low concentration, and that actually is going to bring CO2 out, oxygen going in, and that's how we get oxygen into our blood. We're seeing right now with this respiratory COVID-19, I'll show you essentially what's happening as far as I understand it. Maybe I'll do a little more research and have a whole lecture on that. Probably worth it in this class. So, a brief explanation of lung function testing. It's basically just a measurement of how much you can inhale, how much you can exhale, how much you inhale and exhale on like a breath at rest, and then how much you can inhale beyond that, and how much you can exhale beyond that. So I'm not going to talk about these big graphs. If we were in class, I might, but I'm really just going to focus on this little one right here and say that what a respiratory test really is looking at is right here, from here to here. This, let me get a little smaller one. This is just your normal breathing. So at rest, not exercising, not running, not nervous, nothing like that. That's normal. And then from, let's just switch colors. From here to here is how much you can inspire or breathe in beyond what normal breathing does. And then down here is your expiratory reserve, which is how much you can expire or breathe out beyond max. And then there's a little bit of lung space down here. This is basically you can't expire this. So you can't breathe this out. The person who usually does this test, since this is a class on health science and jobs in health science, it would be a respiratory therapist. So respiratory therapist. This is a good job that does not require a lot of training. It pays a little better than what like a teacher would get, not quite as good as what a nurse would get. And the training is only 2 years, I believe. It'd be a great job for somebody that wanted to go be like a nurse practitioner or go to medical school, or maybe even honestly, if somebody that wanted to maybe have a job be like a secondary thing, if you wanted to say have kids and be more of a mother. A lot of nurses do that so they can take years off. Respiratory therapist would also be a good job like that. Again, not as much pay, but less training and less expensive to get the license. So please, if you have questions about respiratory therapist, post that or email me and I will answer those. All right. Keep going. Again, there's some good quotes in here. First step to make your dreams come true is to wake up and really get to work would be the second thing. But anyway. All right, pneumonia. This is a little bit different than what's happening with COVID-19, but there are some similarities. Pneumonia is a very serious infection. It is a major cause of death among the elderly and children. So this is a major cause of death. You can have them be caused by pathogens, or it can be other causes. Some of the more common ones are bacterial. There's actually a bacteria called pneumococcal pneumonia that will cause pneumonia. Viral is less serious, also very common. I had a viral pneumonia in high school, and it was a walking pneumonia, which basically just means it's not as severe as real pneumonia. I could still walk around while I was on it. And then fungal, these ones can be really deadly. They're usually more common in immunocompromised patients, like HIV patients. This can be a major cause of death. There's two different kinds of pneumonia. Lobar is when it's restricted to one of the lobes. If you remember, I said there were 3 lobes on the right, 2 lobes on the left. And then broncho is when the pneumonia is more in the bronchi. Dyspnea, this O is something we don't use in the U.S. This means it's really hard to breathe or difficulty or abnormal breathing. And then fever, cough. And then can be some real serious complications. Scarring is one. And a lot of, you may have heard that with COVID-19, patients with compromised lung and heart issues are more at risk. Well, pneumonia can cause scarring, which is a permanent issue, and that can make people more at risk. My dad, for example, had pneumonia on his mission, really severe. And he also has a history of cardiovascular issues, even though they're well managed. So it puts him at a higher risk because of that history for the COVID-19. So he needs to be a little more careful than maybe he would otherwise have to be if those things hadn't happened. So I don't want to spend a whole lot of time here because there's a lot of pathology. So let's just skip through this one. This is a good picture though, so drawing really. Basically, this would be a normal lung here. And this would be like after the pneumonia resolved or prior to getting pneumonia. In this case, this is 4, so this would be after the resolution. Basically, you're going to, first people with pneumonia are going to get congested and they're going to get fluid. So in here, in the alveoli, where it should be air, like this, it's fluid. And you get a buildup of red blood cells around it. And eventually your body is going to allow some of those red blood cells are going to diffuse into the tissue along with some white blood cells. And this is going to make it really hard to breathe to have all this fluid in there with all these red and white blood cells. Then the white blood cells will start to win, hopefully, if you're going to get better. And they'll start to remove the fluid and repair the tissue. And then you go back to normal. However, you may have scar tissue that wasn't there before. That makes your lungs function less well after. This is, if you remember, right here we've got a normal alveoli, and here's a pneumonia alveoli. So all these little dark spots, all of these little tiny dark spots, each one of these is going to be the nucleus or the nuclei of a white blood cell. And all that, so here you've got your respiratory alveoli wall, kind of this little lighter color, and then everything inside that shouldn't be there. All that stuff, all this, and all this here. It's all white blood cells. So, yeah, definitely can make it hard to breathe. Lobar, this is what a lobar pneumonia is going to look like on an x-ray. You can see it's restricted to that middle right lobe. You don't have a middle lobe on the left. You only have an upper and a lower, and they separate right about there, I think. Maybe a little lower. But down here would be the lower lobe, middle lobe, upper lobe on that right side. And look at this. This is a upper lobe pneumonia, probably from the, where's the hilum? This would be this side of the lung, because you can see this going down here. Would be going down there. So this is only going to have 2 lobes. This is an upper lobar, left upper lobar pneumonia. You see it on x-ray. This would be from an autopsy. Here is bronchopneumonia, which is again going to be more in the bronchi. You can see it's much more diffuse, which just means it's more spread out, and it looks differently. It's not just restricted to one lobe, but it's restricted to the bronchi, kind of all over. So bronchopneumonia, these are some of the differences. Lobar is more common among healthy individuals that have robust immune systems. Let's see. This is almost always bacterial. This is bacteria. That one, I don't know what the Klebsiella is, to be honest. But different types of pneumonia. Tuberculosis, I am probably going to skip because I don't want to spend too much time on it. This is something that if you ever work in a hospital, they're going to give you a TB test and see if you react to it, see if you've been exposed. This is a great quote, probably one you've heard before. So, I do think for the most part it's true. So anyway. All right, so here we go to COPD, chronic obstructive pulmonary disorders. These are going to be the ones that are more commonly caused by smoking. So you have restrictive versus obstructive. What I really want to just focus on is basically the restrictive ones. We got cystic fibrosis, which is a genetic disorder that we'll talk about. But mainly, I want to focus on COPD and asthma, because these are more common. This is kind of a rare genetic disorder. This is the difference between a restrictive versus an obstructive pulmonary disorder. So see all this here is fibrotic tissue. So this should be healthy lung tissue, and it should look a little bit more like this down here. But instead, you've got all this, and I think they dyed it blue, but all this is going to be fibrous growth that shouldn't be there. And then on this side, what you've got is more of the obstructive type, and you're going to see a lot of necrotic tissue. So when the tissue gets black, it's necrotic. And that means it's dying, and it's, I spelled that wrong, didn't I? It's dying, and it's no longer functional. So different types. Asbestos, you guys may have heard of this. Not something we're going to focus on because it's not so common anymore. But asbestos was this material they used to put in buildings that's needle-like when it's under a microscope, and it's really damaging to lungs. And so a lot of people that worked in factories or buildings that were built with asbestos got this restrictive pulmonary disorder. You'll probably hear commercials for it if you watch like TV too late at night, mesothelioma commercials. So, all right. Let's talk about these obstructive ones. The two primary ones that we're going to focus on are asthma, which this one will be common even among, especially among students. You'll have friends with asthma, or you may. COPD, hopefully you have not been smoking long enough to have COPD. There are other causes of COPD, but generally not doesn't happen in young people. Asthma, so this is what happens in asthma. Here you've got a healthy alveoli or bronchi or bronchiole, actually it looks like, and then this is what happens during asthma. So the muscles tighten. So these muscles right here get thicker. See how thin they are here? Let me switch colors to one that will show up a little better. How thin that is there and how thick that is there. Those will get bigger, and then they also fill with fluid, and this just makes it really difficult to breathe. So abnormal breathing, wheezing, catching for air, just really trying to get air. It can be brought on by allergens or infections. It can also be brought on by sports induced. My brother has that. And then get really viscous, thick sputum. Again, you got all that mucus in there. Look at that, all this mucus in here. And then can lead to a faster heart rate because your body is not getting enough oxygen, so your heart speeds up to try to compensate for that, and it can also lead to chest pain. Asthma can be very, very serious if the person doesn't have their inhaler on them. I believe we're going to talk about treatments later, but this is generally treated with albuterol, which is a steroid. And what steroids will do, this is basically what's happening with asthma. It's almost like an immune response that shouldn't happen. So steroids will suppress the immune system and bring these, take that muscular wall back to being relaxed instead of constricted. So here is just a basic idea of different asthma triggers. So you got different triggers here, different things that can lead to an asthma attack. Then you have a hyper-responsiveness, which is like a oversensitivity reaction or an allergic reaction. And this leads to airflow limitation. You make it very hard to breathe. All right, now let's talk about COPD. I'm going to pause the video and see how long I've been going for. All right, so it's been 19 minutes, and I've still got a decent amount to do. So I'm going to pause here and stop this lesson, and I'll post another one later.